from Shankar Netralaya, Chennai, that where we have analyzed 277 children and their visual outcome, and we have realized that the 1/4 of these children were blind, at least in one eye, when they presented to us. And if you see the etiology of this blindness, and you can see here the 60% of them were suffering from anterior uveitis. So it is very understand that don't underestimate anterior uveitis. It can be a cause of blindness also. So very importantly, you have to differentiate. You have to do the JIA. I always tell ABC of diagnosing JIA. The juvenile idiopathic arthritis can be asymptomatic, though it is not mandatory, but most of them can show ANA positivity. It is bilateral, often associated with band-shaped keratopathy, and these are the notoriously the white eye uveitis, no congestion you will see, and the course is chronic anterior uveitis. Now, the second one, sometimes you see here the three slit lamp photograph I have shown. The first one is a 5-year-old male who presented with an anterior uveitis-like picture, but when we did a UBM, and we can see the seeding in the pars plana region. So it was basically a case of diffuse anterior infiltrating retinoblastoma, which presented like this. The second one, you can see the known patient of ALL, and the patient was under remission, and when she presented like this, kind of hypopyon or the mass in anterior chamber, and it was basically the recurrence of this inflammation. So recurrence of the leukemia. So the third one, you see the 68-year-old female, and it was basically a case of intraocular lymphoma, and which presented like lymphocytic infiltration in the anterior chamber. So sometimes that muscularite syndrome can mimic anterior chamber. Now, coming to that anterior uveitis with hypopyon. Hypopyon is a dreaded sign, and it can be due to infection, and it can be due to inflammation also. Let's see the scenario here. The three scenario of that hypopyon can happen in a patient. Like in first patient, the patient can have anterior uveitis, severe fibrinous reaction, lower backache, and the recurrent attacks of uveitis. And if you do investigation, you may come across like this kind of picture where HLA-B27 is positive, and sacroiliac joint may show effusion. So it was a case of HLA-B27 associated uveitis. The second picture, it can be a panuveitis with mobile hypopyon, and if you take the history, patient can give you a history of recurrent oral and genital ulcer, and you further investigation, you can send the patient to a rheumatologist, and you can do HLA-B51, though it does not rule out or rule in the diagnosis of Behçet disease, but it can be a second picture. Let's see the third one. Now, third one can be another, again, case of panuveitis with hypopyon. There may be history of hospitalization or prolonged diabetes mellitus, and patient can give you a history of septic foci like a big abscess in the thigh. So this patient, if you send to a vitreoretinal surgeon for vitreous biopsy and start doing the blood and urine culture, so it can be a case of endogenous endophthalmitis, which can present as hypopyon also. So you have to know all the spectrum of this entire hypopyon manifestations. Now, coming to that another entity, I consider it as a red flag signs, because this is a 27-year-old male, known patient of HLA-B27 associated uveitis, history of recurrent attacks of inflammation, and the patient is steroid responder. Why I'm telling that this is a case of red flag signs? Because you need a different strategy to manage this case. Because the patient is steroid responder, you can't every time treat the patients with topical steroid, which will again cause the secondary glaucoma and other. So these are the patients you have to take care from the beginning. You need to start this patient on early immunosuppressive, so that the recurrence, you can bring down the recurrence, and you can actually reduce the inflammation or recurrence in these patients. Now, this is my last point, that anterior uveitis, you know that there are the diffuse scleritis are associated with 40% of systemic disease. It can be initial manifestation. And in cases with necrotizing scleritis, it can be as high as 95% of the systemic association also. So sometimes this anterior uveitis may be some scleral congestion, can be presenting sign of rheumatoid arthritis, granulomatous polyangiitis, relapsing polychondritis, and various other systemic diseases disease. So you need to start treatment very early stages, so that these are, most of them can cause lethal vasculitis. So your primary aim will be not to save only the eye, but also the life of the patient. So if you can diagnose, decode this anterior uveitis with systemic manifestation, you can actually save the life of the patients. Thanks you. Thank you.
Okay, thanks very much, Partho. A terrific talk. We've got probably time for one question, if anyone has any. Yeah.
A very nice talk. I'm a rheumatologist. So I just wanted to know that we often get patients with, say, 2 episodes of uveitis in a year. So generally, we don't start these patients on methotrexate. But they are steroid responders. Some of the ophthalmologists give topical steroids and some give oral steroid depending on the severity. So in these cases, do you recommend that methotrexate should be started?
If the patient is steroid responder, I feel it is always better. But because you can't predict the recurrence rate here. Oh, no. So we are talking about steroid responder in ophthalmology. Abra is my rheumatology friend. So at steroid responder means that if 15% of our population, they respond to any form of steroid. The moment you give any form of steroid, there will be a hike in the intraocular pressure. Okay. So they develop glaucoma. We call it steroid response glaucoma. So we are talking about that thing.
Okay. Thank you, sir.
Okay, thanks very much, Partho. Oh, yeah, sorry.
What would be the best immunosuppressive you feel in children in any of these entities?
See, children, if you talk about this GIA group, no, I feel the adalimumab is nowadays best. But the problem here is, many of our patients can't afford the cost. So the preferred, I think, Abra will be the best person. I think methotrexate is the...
Thank you.
Okay.